When we look at medications, we were very fortunate to have a whole stable of new medications that are targeted against specific molecules. But that's not to ignore that legacy or older molecules are also targeting, maybe not so specifically. In terms of a legacy medication, when I first started practicing, it was a brand new medication that was Methotrexate. And we use it in a very different way. A few tablets once a week and that sort of thing. And what I found is that it wasn't really very effective in the way we were using it. So we started pushing it a bit. And then we started combining it some. And then we said, well, it's still not as good as we'd like. So at that time, I was using combination therapy with methotrexate and hydroxychloroquine, which is very common in a combo at the beginning. And I said to my colleagues, well, I'm not sure the Plaquenil is making any difference in my new strategy where I was using sub-Q methotrexate because we knew it was better absorbed and we've learned from CATCH that it's better tolerated. And so I'll do that. I'll stop. I won't use Plaquenil in the patients anymore. I'll just use the methotrexate. And then we've learned further in our practice in Newmarket that if you get methotrexate, you usually get sub-Q. And we did a study again with our patients within CATCH and looked at how quickly they got better. Well, half of them were improved within 6 weeks, and 50% were in a low disease or remittive state at 12 weeks. That's as fast as any biologic. And then we did another study within CATCH, one of our other colleagues, looking at how long you can stay on an oral methotrexate versus a sub-Q methotrexate. And surprisingly, the patients who are on sub-Q methotrexate both tolerated it better and had a better outcome and stayed on it longer. The usual wisdom is the more medication you get into your system, the more likely you'll have side effects. But that doesn't seem to be the case when you talk about sub-Q versus oral methotrexate. Probably has to do with the absorption going through the liver first, but we really don't know. But what we can do, definitely tell you that if you start sub-Q methotrexate, you're more likely to be on a longer period of time with a good result. Now, just to inform people as well, is that not all our patients will need to stay on sub-Q methotrexate. Many decide that they won't change because they like the sense of it, but we do offer people at the beginning, after they've agreed to the sub-Q, that they can go to the oral. We always make a contract of what we're going to be presenting to you, what are the side effect profiles, what are our expectations of outcome, and in what period of time. And we tell them we've always got their back. So people often want to know, whether when a diagnosis is made, I've read about rheumatoid arthritis, it's a crippling disease that I'm going to have for the rest of my life. And that was certainly true when a diagnosis was made some years ago. With the new strategies of early assessment, early diagnosis, early initiation of therapy, and getting people quickly to a state of improvement, and we can do this as part of CATCH. We can look at our own group. We had a medical student a couple of years ago who looked at our patients in remission, okay? And what we found is that in our cohort, we had 48% that were in a remission, not just a low disease activity state, in a remission. 20% of that group were medication-free. 70% were on monotherapy that they'd started at the beginning. So the concept that having a diagnosis of rheumatoid arthritis requires a march through multiple medications over time is not borne out in an approach where you optimize early treatment, early improvement, and sustained benefit. It is really pretty successful. That's new information. That's not in the textbook. That's from the information that we gather from CATCH in our circumstances. Side effect profiles of medications are pretty clear. Hardly any medication is without a potential side effect. Clearly, what has to be provided to patients from the get-go, whatever the medication is information about what to expect. Not only just a listing of them, but probability. And then when you know that there are some side effects that are predictable, how can we avoid that side effect? Well, if it makes you feel nauseated, maybe take it at bedtime. We used to give folic acid, which, as most people know, is commonly used during pregnancy to prevent neural tube defects and things like that. But that wasn't successful in a significant number of patients. Well, folic acid is closely linked to B12, vitamin B12, which we get in our diet pretty easily in North America. So what we said and we're very proactive about this, is that if you're over 65 and you're starting methotrexate, we're going to give you B12. There's no side effects to that medication. And if you're under 65 and you have side effects and or your levels are in the lower end of it, we'll give you B12 anyways. So I'm trying to be very proactive. It's an injection once a week. Why injection? Because absolutely 100% absorbed again. And it's the same needle.